Okay, this is an overview of volume responsiveness and cardiac output. We're going to start with a lot of physiology, particularly around venous return physiology and IVC physiology. This is critical for understanding how to interpret volume responsiveness, particularly if you're going to try to use an IVC ultrasound. Now, I'm going to spend about 15-20 minutes here telling you why IVC ultrasound is actually very unhelpful in many ICU patients. But for some patients, it is helpful, and it's also a good opportunity to review the venous return physiology before we talk about some other ways of measuring volume responsiveness and cardiac output with the echo probe. So let's start with a case. We have a 65-year-old man with HFrEF, COPD, and CKD stage 3 presenting with fevers, leukocytosis, and a new infiltrate. Now he's already gotten 3 liters of IV crystalloid fluids. His blood pressure is soft. Don't say soft, just say hypotensive. He's hypotensive, he's oliguric, and his creatinine's elevated. And we get this type of IVC ultrasound. And we're sitting there at the bedside, and we're really just wondering what you're probably wondering: should I give him more fluids or not? And the answer is, I don't know. So before we go too far, let's remind you what constitutes volume responsiveness. I don't mean to insult your intelligence. Hopefully you know this stuff in and out, but if you don't, just a quick refresher. Volume responsiveness typically means a 15% or so increase in cardiac output with a fluid challenge of 500 mLs. And volume responsive patients, when you give them this fluid bolus, will have a big shift in their venous return function curve, because mean systemic filling pressure has been increased substantially and cardiac output has also been increased substantially. However, volume non-responders, when you give them this fluid bolus, even though you're shifting the venous function return curve to the right, or venous return function curve, whatever you want to call that, to the right, you are not substantially increasing cardiac output. So this is your flow or your contractility on the y-axis, pressure on the x-axis. When you're shifting the venous return curve here, you are not getting any more bang for your buck. Cardiac output is not really increasing. So this first part, we're going to talk about the IVC ultrasound is mostly crap in the ICU, and if you're using it, you need to try to find other ways to improve your volume responsiveness exam when you're trying to figure out if you give people more fluids. So when, again, I'm looking at this patient at the bedside, and somebody's showing me this IVC ultrasound, and I have a bunch of questions. What is his body size? Is he on the vent? Or is he breathing spontaneously? Is he breathing spontaneously on the vent? What is his effort of breathing? Is he at risk for intra-abdominal hypertension? All of these things will affect the IVC size and its different characteristics throughout the respiratory cycle, and I need to know some of this information if I'm going to decide whether or not to give him more fluids. And even if you can answer these questions, the IVC is still mostly crap in patients like this guy. So let's go through the physiology. Now these are a lot of the pressures that influence the size of the IVC, but not all of them, and we're going to talk through this a little bit more carefully. So the first premise we've already reviewed. The right atrial pressure is critical. It is the intersection of the venous return and Frank-Starling curves. So we've already looked at these curves, and in the intersection of these 2 points is the right atrium. So as cardiac output increases, you can increase venous return, and you can shift this upwards, or sorry, it'll stay the same basically. You can shift this curve to the right and increase right atrial pressure, which up to a point will improve cardiac output, but it's actually the intersection of these 2 curves that determines your cardiac output. Now, this right atrial pressure is context dependent, right? So in most clinical situations, we're making assumptions about both curves. So if we have a young, healthy person who comes in with early septic shock, they may have a very vigorous myocardial contraction going on, and their contractility has this very steep curve to it, so that even if you have a lot of room to continue to volume expand them, it's still a good increase in your cardiac output with that volume expansion. As you move that venous return function over, you're going to keep getting more and more cardiac output up to a point. On the other hand, if you have an older person with bad HFrEF and they're in cardiogenic shock, well, clearly if they're hypotensive, fluid bolusing is not the best option here. You're not really going to get much more cardiac output out of additional fluid boluses. Now, when we looked at our patient, I really don't know. Does this patient have decent contractility? Is it actually vigorous contractility? Is the contractility impaired? So I don't know what this curve looks like, and I have no idea where my 2 curves are intersecting if I don't know what my contractility is doing. And that's often difficult to ascertain at the bedside, which is why people have disparaged right atrial pressure except for at extremes. When somebody has a very low right atrial pressure, no matter what curve they're on here, they're likely to be volume responsive. Similarly, if they have a very high right atrial pressure, no matter what curve of contractility they're on here, they're probably at the flat portion of the Frank-Starling curve. So that's why right atrial pressure really is mostly helpful in extremes when you're thinking about volume responsiveness, and even there it is still context dependent. So again, just a reminder, a fluid bolus is intended to increase cardiac output by increasing the mean systemic filling pressure, which I've already showed you. That's volume responsiveness. So if you give a fluid bolus and you shift this curve over, you're shifting the mean systemic filling pressure, which is the intersection of the x-axis here, rightward, in both these situations. Now the rightward shift in this case gave me a big increase in my cardiac output. It went from here to here. On the other hand, here did not do that. So that's what volume responsiveness is all about. And the reason we spend so much time talking about right atrial pressure as we start to think about the IVC pressure is that these are two very closely linked pressures. Now, they can't be identical, otherwise there'd be no flow, right? So if the IVC pressure was actually lower than the right atrial pressure, then there would be no flow to blood. If they were equal, there would be stagnant blood. Now, sometimes throughout the respiratory cycle, if patients have high right atrial pressure, there is stagnant blood. But overall, there needs to be some pressure drop for venous return to continue, right? The femoral pressure needs to be slightly higher than the IVC, which needs to be slightly higher than the right atrial pressure. Otherwise, blood would be completely stagnant. Thus, we're really curious about the right atrial pressure and IVC pressure right at the level of the diaphragm here because they're really closely linked. And in fact, as you will see, these first four premises explain why using IVC is often considered a slightly better CVP. So you can actually see that the PIVC is essentially functioning like your right atrial pressure in this intersection of the venous return function and the contractility curve. Okay, so venous return is impacted by all the things you see here. So femoral venous pressure, splanchnic venous pressure, which are related to your mean systemic filling pressure. As you tank up patients with fluids, you're increasing these pressures, the P-fem and the P-splank. You're also going to be indirectly increasing the IVC pressure. But this is all what affects venous return. The pressures in these vascular beds, these venous beds, as well as the upstream pressure from the PIVC and ultimately the PRA. So if PRA is low, blood can freely flow into the right atrium. If PRA is high, there's reduced ability to achieve venous return. Okay, moving along, here's the next premise. When you measure IVC diameter, you are measuring volume and inferring the pressure, right? So when you're looking at this with an ultrasound beam, you're doing a volumetric assessment. You're looking at the diameter at a minimum, right? And that diameter is reflecting a volume of the IVC, not a pressure in the IVC. And now we know how, volumes and pressures are related. We are ICU doctors, we do this all the time. IVC compliance is going to be the key variable that links the change in volume to the change in pressure. So we have to know a little bit about IVC compliance, make some inferences about it when we're thinking about how the IVC is behaving throughout the respiratory cycle, if we're going to use it to assess volume responsiveness. And ultimately, we'll see that the IVC volume and the IVC pressure depend on every single variable depicted here, including what is called a critical closing pressure. Now, the closing pressure is the point at which the vein will simply collapse on itself under its own weight. The vein is a collapsible structure. All veins are collapsible structures. They have a little bit of elasticity to them, as we all know. But once the pressure drops in them, they collapse, right? You see this when you try and insert a peripheral IV in somebody who's hypovolemic. The same thing happens in your IVC. There's a critical pressure at which the veins will collapse on themselves, and that's called the closing pressure. So all of the things in this picture will impact what the pressure in the IVC is. The downstream pressures from the femoral and splanchnic venous beds, the upstream pressure in the right atrium, how the pleural pressure is interacting with the right atrial pressure, how that pleural pressure is being transmitted through the diaphragm with a force that impacts abdominal pressure as well as splanchnic venous blood flow. And abdominal pressure and the closing pressure will impact how the IVC behaves as well, right? If the pressure outside of the IVC is high, the IVC will collapse. So all of these things impact your IVC ultrasound assessment. So this is probably why IVC ultrasound in a lot of ICU patients isn't as helpful as you might have thought, because there are so many variables here and it's difficult to measure these. In fact, which of these can you actually measure directly and reliably and continuously in the ICU? Well, not a lot of these, right? We don't measure pleural pressures very frequently. At least in my ICU, we're not putting esophageal manometers down. We're not regularly transducing intra-abdominal pressure, but we could through Foley, obviously. We're not measuring IVC pressure directly. We have really no good way of measuring splanchnic venous pressure. Femoral venous pressure, I guess we could measure if we had a femoral line in, but that's not something we're routinely doing. And we don't necessarily know the closing pressure. So we can't really know all of these things. So that's why, in general, the IVC ultrasound is so limited in our critically ill patients. So if you've been using it for your volume responsiveness, you should recognize there are only a handful of scenarios in which it's helpful. And that's what we're going to talk about now, when the IVC ultrasound is actually not crap. So here are a few situations when it's not crap, when it actually might be useful. And the first situation is when a patient is stuck with what's called zone 3 physiology throughout the respiratory cycle. Now, some brilliant physiologists about 30 years ago did a beautiful study looking at IVC size and flow with different conditions of abdominal pressure, and they found that there are different zones in the abdominal compartment, like there are west zones of the lung. And zone 3 physiology is this: when your IVC pressure constantly exceeds your abdominal and closing pressures throughout the respiratory cycle. So when we say someone's stuck in zone 3, their pressure in their IVC is the fixed upstream limitation of femoral venous flow. So venous return from the periphery is limited only by the IVC pressure, right? If the IVC pressure is always higher than the abdominal and closing pressure, so the IVC is always distended, so venous return is only going to be impacted by the pressure on the IVC, and then our IVC to right atrial flow is going to be dictated by the right atrial pressure. So it's going to be how these two pressures interact that's going to impact cardiac output. So hopefully you can understand then that near maximal venous return is already occurring when I am in a zone 3 condition. When my IVC is sort of already distended, my venous return from the periphery is going to be only impacted by my IVC pressure, not these other major influences. And then cardiac output and venous return into the right atrium are going to be just dictated by the right atrial pressure. So these patients are already experiencing near maximal venous return, and they're not going to be volume responsive. It might be helpful to contrast these patients. All right, so we're going to see that here. So femoral venous blood flow is limited by IVC blood flow, and then IVC blood flow is impacted by the right atrial pressure. So here's an example of patients in zone 3, and we'll contrast this to zone 2 in a second, but this is a zone 3 patient. You've seen IVCs like this before in your ICU. This patient throughout the respiratory cycle has a very dilated IVC, so there is never any collapse. So venous return is only impacted by how fast the right atrium empties, which is going to be cardiac output. The pressure drops in the right atrium, but the IVC pressure is going to be the limiting factor for venous return from the periphery. So in this patient, we know we can measure the IVC is 2.41 centimeters. Whether or not he's on a vent, I think he was. It doesn't matter. There's really not a whole lot of change throughout the respiratory cycle. Perhaps it shrinks a little bit, but that might just be motion artifact. This patient, as we saw in the video, though, has no variability in their IVC size. So this is a patient who's clearly not going to be volume responsive. They're stuck in this zone 3 physiology. So let's contrast that with patients who are stuck in zone 2. This is the other situation where IVC ultrasound might be helpful or might be useful. If someone's stuck in zone 2 physiology and we presume they have a normal abdominal pressure, well, we can see how this would be helpful. So zone 2 physiology is this: when the abdominal pressure and the closing pressure constantly exceed IVC pressure throughout the respiratory cycle. Now, when you're stuck in zone 2, the femoral venous flow is not going to be limited by the pressure in the IVC. It's going to be limited by IVC collapse from these other two pressures outside the IVC. And the right atrial filling similarly will be limited by the IVC collapse, which again is dictated by this sum of the abdominal pressure and closing pressure. And we'll see that here. So if patients throughout the respiratory cycle have a high abdominal pressure and closing pressure that exceeds the IVC pressure, the pinch point is going to be that external pressure, not the pressure in the IVC itself. So this would imply that somebody's volume responsive. If we can increase the mean systemic filling pressure and cause the pressure in the IVC to be increased, it will counteract the effects of the abdominal closing pressure, and we're actually going to continue to improve venous return and cardiac output, because now we're going to counteract these collapsing forces of the abdominal and closing pressures. So it's not common you actually find someone in zone 2, strictly zone 2 physiology, but this is an example of a patient who is. And the reason you don't see this very often is because, actually these are the patients you probably thought you couldn't find the IVC, but these are the patients, in fact, that have such a flat IVC, and that's why you couldn't find it. So this is a patient who had end-stage renal disease and came in with a PEA, cardiac arrest, and actually figured out pretty quickly why we could not find his IVC. When we finally did, we saw that it was just completely collapsed. So this patient was stuck in zone 2 physiology, where the abdominal pressure and the closing pressure of the IVC were prohibiting further venous return from the periphery. So this patient simply needed more volume back. After his dialysis session, he was too dry, went into PEA arrest because there was no venous return. There are two more useful scenarios with using the IVC ultrasound, which you're probably familiar with. The next is when patients are passive on the vent, and that's another useful scenario. So when patients are passively ventilated, and you know that their pleural pressure is increasing during inspiration, and you have a sense of what that pleural pressure is because they're passively ventilated, you can look at your ventilator waveforms and see what the airway pressure is throughout the respiratory cycle, and make some inferences about what the pleural pressure might be doing. You can see that the diaphragm is going to push on the abdomen and the splanchnic blood. So in the passively ventilated patient, this pleural pressure is going to increase. It's going to displace the diaphragm with a force, and that's going to cause the splanchnic venous blood to be mobilized. However, at the same time, that increased pleural pressure is limiting venous return. It's prohibiting IVC emptying into the right atrium. So that venous return is impaired by intrathoracic pressure. And if there's a lot of room for taking up the blood vessels, you're going to get this nice distensibility of your IVC. So if patients are going to be volume responsive still, when you increase that pleural pressure, you're going to mobilize some of that mesenteric venous blood, but it's going to hit a wall. And if you get a large amount of distensibility, that implies that there's a lot of capacitance still in the venous system, and the patient is still going to be volume responsive. So as we can see in passively ventilated patients, who are receiving a tidal volume of 8 mLs per kg ideal body weight, a distensible IVC somewhere in this range of 12 to 21% is going to predict fluid responsiveness quite well. These are really good likelihood ratios for predicting fluid responsiveness. The question I have for all of you is, how often do you have a passively ventilated patient who is getting a tidal volume of greater than 8 mLs per kg? I don't see that very often. So this is, a potentially useful scenario, but not one we see very often. Here's the final useful scenario. This is a spontaneously breathing patient, but one who has minimal effort. And I say minimal effort because pleural pressure is going to impact how all these things behave. So if my spontaneously breathing patient has a decrease in their pleural pressure during inspiration, but their work of breathing is not dramatic, their pleural pressure is not dropping dramatically, then you're going to see how this is going to be helpful in those situations. My pleural pressure is going to drop, which is going to drop my right atrial pressure, but I'm still going to have descent of the diaphragm. So I'm still going to have displacement of my splanchnic venous blood. However, because my pleural pressure is dropping significantly, my right atrial pressure is going to drop, and that's going to allow my IVC to empty. And the blood flow from the IVC to the right atrium is going to be more than the blood flow from the splanchnics. So in that situation, I'm also going to have a tendency of the abdominal pressure and the closing pressure to collapse my IVC. What I've done here is, by decreasing pleural pressure, I've dropped my right atrial pressure. Even though there's mobilization of my splanchnic venous blood, I've dropped my IVC pressure even lower than the abdominal and closing pressures, so there's a tendency of the IVC to collapse. And again, you've seen this before, but this is in spontaneously breathing patients in whom there is not a huge drop in pleural pressure. Or again, we're making some inferences at the bedside. If there's lots of work of breathing and we're making some assumptions that the pleural pressure is dropping to -40 or -50, which is very feasible in healthy young people who have a high work of breathing in a shock state, then of course their IVC is going to collapse. You're having a huge pleural pressure drop and a huge surge in venous return. Now, they're still probably going to be fluid responsive, but just recognize that's a potential limitation when you're interpreting IV collapsibility in spontaneously breathing patients. Formula is here. And collapsibility, usually defined as 35 to 50% in spontaneously breathing patients, also portends a pretty significantly helpful positive and negative likelihood ratio for volume responsiveness. Now, these are the ranges reported in the literature, and there's a bit of a range, again, because patients have different physiology, right? Some patients have significant swings in pleural pressure, and some don't. And those that don't have big swings and have this huge collapse in their IVC are likely to be much more volume responsive than those that are having only collapse with really big swings in pleural pressure. So we're going to round out this part of the talk with, again, revisiting why the IVC ultrasound is crap in a lot of our ICU patients. And this is why, because many patients have cyclic changes in these pressures throughout the respiratory cycle. So they're constantly transitioning between zone 2 and zone 3 physiology. And again, without knowing what the actual intra-abdominal pressure is, the IVC pressure, without knowing pleural or right atrial pressures, femoral pressures at any given time, we don't necessarily know why the IVC is behaving the way it is. And they're constantly flipping back and forth between a condition where the abdominal and closing pressure are slightly higher than the IVC, or back to where the IVC is slightly higher than the abdominal and closing pressure. And this is the example I gave you from the beginning. So this is my HFrEF patient with stage 3 CKD who's on the vent but breathing spontaneously with a lot of effort because he's got COPD and he's auto-peeping or something like that, and he's belly breathing, whatever that is. So I'm not sure how to interpret this because I can't tell you what the pleural pressure is at any given point in time. I can't necessarily tell you what the abdominal pressure is at any given point in time. So I'm not sure if this patient is going to be volume responsive or not. Here's another example that shows you some of the limitations of the IVC ultrasound when you're trying to assess volume responsive. This is a patient who may have both zone 2 and zone 3 physiology, just at different parts of their IVC. So this is a man who has restrictive cardiomyopathy, a huge right atrium. His IVC is enormous at the point where it's emptying into the right atrium. But then if you just go a few centimeters down the IVC, he had this enormous liver that was so congested, it was so heavy, it was compressing the IVC. So you'd say, well, here, the abdominal closing pressure are probably higher than the IVC pressure. It's going to start to cause it to collapse. But once you get closer to the right atrium, it's more of a zone 3 phenomenon where the IVC is pushing back. So, this is a patient in whom somebody else actually incorrectly decided he should get more fluid because they saw this IVC was small and they measured it here. Well, the man's right atrial pressure when I saw him after he got a 500 cc bolus was like 23 or something. So the patient was had a ridiculously high filling pressure on the right side, and that was not well appreciated because some of the pressure outside here, particularly from the liver, was causing the IVC to become partially collapsed. So these are the limitations to consider in using an IVC to predict fluid responsiveness. There's some difficulty with maintaining accuracy of measurements with vigorous respiratory effort. If the IVC is swinging in and out of view, it's hard to make sure you're staying in plane. So that's one limitation of it. The next is that there are no standards for correcting for respiratory effort. And I've alluded to this already. If somebody's having vigorous work of breathing and huge drops in their pleural pressure throughout the respiratory cycle, the IVC is going to collapse. It's going to collapse if there's a negative pleural pressure of negative 50. It's going to collapse in everyone. And whether or not that patient is volume responsive or should continue to receive IV fluids, I leave that up to you. We know that over resuscitation, particularly in late sepsis and other critical illness states, is not a good thing. Patients need to get that fluid mobilized at some point. Again, if there's a significant abdominal breathing, abdominal contraction, or increased intra-abdominal pressure, it's hard to know what to make of that IVC collapsing. They may not necessarily be very volume responsive, particularly if the increased intra-abdominal pressure is due to third space belly fluid. Is that somebody you want to keep loading with fluid? I don't know. Then finally, most of my patients in the ICU, we try to lighten sedation, we try to, do this sort of stuff, right? So if they're ventilated on a non-invasive ventilator or vent, but they have active breathing efforts, I think their IVC ultrasound is basically uninterpretable except for at the extremes. So again, if they're zone 3 and they're stuck in zone 3 and the IVC is completely dilated throughout the respiratory cycle, well, then I know they're not going to be volume responsive. Similarly, even if they're on a positive pressure vent and their IVC is completely collapsed, well, wow, that patient's going to need a lot of volume. They're going to be very volume responsive. They're stuck in zone 2 physiology. But as we said before, a lot of these patients are stuck in this in between where they're in zone 2 and zone 3 and it's swinging back and forth and you don't know what's happening outside the IVC with respect to pressure around the IVC, and it's hard to know what to make of it. So here's the summary, here's the data. The extensible and collapsible IVCs are helpful in the right patients, in the right context, and they give you pretty good likelihood ratios for predicting fluid responsiveness. They're slightly better, in fact, they're quite a bit better than an invasively measured CVP when you use a CVP at an arbitrary cutoff, for example, of 8. Now, of course, at extremes, CVP is helpful too. And in fact, you'd probably say at extremes, your CVP is going to be just as predictive as your ultrasound for predicting fluid responsiveness. So the patients who are going to have this distensible IVC or a collapsible IVC and spontaneously breathing patients are probably patients with a CVP of 0 to 2. Similarly, the ones that are going to be non-distensible or non-collapsible are going to be the ones with the CVP of 12 to 15. So at extreme, CVP probably predicts fluid responsiveness to the same degree as the IVC ultrasound. And in fact, that's not surprising. Then there was a meta-analysis recently I saw that showed that in heterogeneous ICU populations, the area under the receiving operating curve was only 0.62 for IVC measurements and predicting fluid responsiveness. So that means, it's slightly better than a coin flip. The area under a receiver operating curve of 0.5 would be a coin flip. So 0.62 is not great. You want something close to 0.8, 0.9 if it's a really helpful test. And that's why it's not super helpful. So I encourage you to watch the next part of this series, which talks about better ways to assess volume responsiveness, particularly by focusing on measuring cardiac output dynamically.